So I'd like to begin with two questions about Medicaid. One is about, what's your sense of how Medicaid managed care is evolving? What are some of the changes in the way it's being done, if at all? Or is it very stable and it's just expanding as more states convert to it? Sure, Matt.
Well, I mean, we're at an interesting time for Medicaid managed care. Obviously, right now, the market is freaking out about whether we're going to lose the entire ACA Medicaid expansion. Leaving that aside for the moment, Medicaid managed care generally is now penetrating the high-spending, more vulnerable populations, and that's a controversial move. It's not yet fully proven that the Medicaid managed care organizations can do a good job with those populations, balancing cost containment against the need to protect the care relationships and patterns that those members are seeking. So this is where we are, and whereas today more than 2/3, maybe 3/4 of the total Medicaid population is already in managed care, it's also true that only about 40% or so of the total Medicaid spending, federal and state dollars combined, is actually in managed care. So you have this, that mismatch is basically because of the high spending populations, dual eligibles, LTSS, that are not yet in managed care.
Thanks. And I take it we've had a few years' experience now of hospitals with the Medicaid expansions, and what is the bottom line a big positive for hospitals?
So clearly the one source of identifiable benefit in exchange for $155 billion in cuts over 10 years to pay for it has been the Medicaid expansion impact on the hospitals. You can actually see, and looking back at hospital by hospital data, which I've done, the compression of results through 2013 cost report year, and then this very rapid expansion of EBITDA and EBITDA for those hospitals in the, not so much the 14 year, but in the June 15 year data. You can see it in 14, so you can go from 13 to 14, all of a sudden you see a little uptick. And from 14 to 15, you see a strong move towards profitability in Medicaid expansion states. And it's especially true in the rural hospitals because I cover a company called Quorum, which has 38 rural hospitals, and Community Health Systems, which has 150 hospitals at the moment, and a very strong proportion of those are rural or in small cities. And you can actually see in the data for them, as well as for Tenet and other companies with a bigger relative exposure to Medicaid expansion states, that—
Could you silence it, please?
Thank you. That there is a very significant uptick in profitability. More so, and what's interesting is you see it in Pennsylvania. You begin to see it in 15 numbers that you didn't see in 14 numbers. So you know it's related to a Medicaid expansion because they were late to expand. If the Medicaid expansion were somehow, for example, in some of my fondest imaginations about what could happen positively here, one might argue that Medicaid block grants might give some of the states the optionality to say, well, no, wait a minute. If we're going to sustain the level of current spending and per capita, and the number of capitas is higher in states that are Medicaid expansion states, then states that didn't expand will get less than states that did expand, okay? So maybe if I'm running one of those states, then wait a minute, before all this gets started, I want to make sure I get as much as I can from the federal government. Therefore, maybe now that it's Republican controlled, maybe it's, you should excuse the expression, kosher for us to go ahead and expand Medicaid, because now it's a Republican idea, it's going to be endorsed, and we're going to have complete control over how we do it. There's no strings attached, et cetera, et cetera. So you could actually see that benefiting the hospitals. That would be one ray of hope and light that I would sort of hand out there for the hospitals. But they very definitely have benefited from that piece in particular. The exchanges, obviously, The hospitals have benefited where the health plans have not, because they've been the beneficiary of where much of this excess cost of the adversely selected risk pool has been showing up, certainly initially showing up in the emergency room, and then, to the extent that they had poor health status coming in follow-on care. But, what's really interesting from a stock market perspective is before the election, reform was good for hospitals, but reform's impact was dying out. And so there was already a bear case out there for owning the hospitals, and the hospitals had already come down strongly off their highs when it became very much apparent that volume comparisons were tougher and that they weren't seeing volume growth, and that, we attributed much of this to the fall-off effect of not having enough new people enrolling in the ACA-sponsored plans, be it Medicaid expansion plans or Medicaid expansion or exchange plans. And so there was already a bear case coming into this that reform wasn't good enough for hospitals. And so now you just compound it in whatever they had before, which was been 5 or 6% of their EBITDA, depending on who you were talking about, maybe a little bit more for some of the companies, will now go away as your worst case scenario. So it can put the hospitals in some pretty dire straits, like the point that Anna made, that the managed care companies have had very significant negative impact, cuts in advance of coverage, tax in advance of coverage. So have the hospitals. I mean, these groups, all the groups that who saw Medicare reimbursement cut, which are not just the hospitals, they're the post-acute companies. They're included in the ACA, for example, is also home health rebasing and things like that. All of them have paid for it, but the ones that have benefited most from it have been the hospitals.
Okay, let me.
Can I ask a question to Sheryl? What about, I think the dish cuts, the dish cuts are supposed to be, are on the docket, I should say, to be repealed as well. So what would be the net impact, you think, going back to the original, dish payments relative to not having Medicaid expansion?
What was interesting was that most of the publicly traded companies did not have that much of a negative impact of dish cuts as we looked around at what they were. And in fact, some of them, the way in which the formula for the dish payments depended upon how many uninsured there were in the state prior versus how many uninsured, what the reduction has been, and it was tied to that. And so as a result, most of the, not all, but most of the companies actually were expected to get an increase in dish payments in the early part of the ACA, not a decrease. Modest, but an increase, which was a counterintuitive outcome, but, it was formulaic, and that's what happened.
Yeah. I'd like to go into the questions about alternative payment models, value payment, what we're calling it. First, I want to ask about provider perspectives on ACOs and bundled payments. How eager are they to engage in these contracts? What role do they see this is going to play in the future?
So I'll take a crack at that one, since it's really actually quite interesting. So the premise of an ACO, fundamentally, if you're a hospital, is to empty out your hospital beds, because hospital care is expensive and it's not always appropriate. And so the trick was that you would see increased market share, but you would see fewer of those patients, fewer hospital days per patient of your current population, but you'd have a bigger population. And, I love the argument, well, we'll make up on volume what we lose on price. It doesn't often work that way. So, it's been, generally speaking, the Medicare ACOs, as we know, have not been successful for the hospital participants, but for a handful. However, what we are seeing is hospitals expressing, and provider groups, physicians as well, expressing significant interest in joining population health-based plans. Everybody was preparing for these sorts of things. It was all paid for, instead of fee for service, it's going to be fee for value, it's going to be outcome oriented, it's going to be tied to quality. And some of that's already happening, but what we're not seeing, or what we haven't seen, are these broad-based move towards population health at-risk plans being offered or negotiated by the health plans and the hospitals. That has not happened. And if you talk to some of the bigger providers out there, like HCA, they'll say to you, we would be happy to explore that if somebody would offer it to us, but no one's really offered it, and we're not going to give a discount that we haven't been asked to give. So, it is a bit of a challenge to see how that, how the hospital-driven ACOs would ever be, fully accepted by hospital management teams, because it's just an anathema. It means you have to empty your beds, and that's their model. On the other hand, where we have seen a lot of ACOs being formed is between the physicians and the health plans and other provider groups and the health plans. And, there are well over 750 of them around, just we'll call them well-defined, actually, ACOs, but there are many other kinds of variations on this that have been tried. It's not clear what impact they're having on utilization. It's not clear what impact they're having on changing behavior. But, where there is some evidence of at-risk schemes and arrangements, they do seem to have the effect of changing provider behavior, which changes specifically physician behavior. Since they, are the start and they're the source of all of this, it's also changing consumer behavior. But not nearly the kind of impact that you would have expected.
I think bundling, there seems to be appetite. I wouldn't say that they're wildly enthusiastic on the public side, but, Tenet and HCA seemed relatively positive. And I've talked to some of the not-for-profits. They're quite positive. And they're saying
bundling's a difference. Bundling is a different story. It's not an
ACO, but bundling I think they like. So it's the price discount off the DRG, but they think the offsets from the post-acute squeeze and a little bit of an increase in length of stay, they still end up expanding their margins, and some of them are touting that they'll be more profitable and growing faster. So we'll see.
So perhaps the rule is that what's interesting to you as a provider is an arrangement where there are other provider services that you can succeed by cutting. But if it's your own services, like the hospital with the ACO, you won't do that.
Yeah, it's a zero-sum game, and I guess someone's got to get squeezed.
Actually, it's going to be a negative-sum game. So at some point, the hospitals are going to realize that their lengths of stay are going to be compromised. See, it's not really a fair test yet, because CJR hasn't put the hospitals at risk yet. They don't go at financial risk until next year. So this is all experimentation, and they're learning, and it's nice to have a year where it's phased in, where you get to learn. But, it's still fee-for-service reimbursement for each of the slivers, and then they'll figure out, this amount later on, how much of a benefit or a cut you're going to get. So it's going to be an interesting, it's going to be very interesting. I will say, though, that the data that's come out from BPCI and Health Affairs was fascinating, because you didn't get the increase in home health to the extent that you thought. You saw some increase in home health. You saw a very steep decrease in subacute nursing home care, but not in home health. And so the question is, where are these patients going? Are they going home with no follow-up care, or are they going home with outpatient? Can they actually drive? Are they not homebound? It's really fascinating to see how this is really changing the practice of medicine using financial incentives, and that's what it's all about.
Good. Okay. What about to what extent are hospitals or physician associations, physician organizations, working closely with selected post-acute providers on either ACOs or bundled payment? Just want to look at the partnerships, the relationships.
So you've seen community health systems, which has a bit of a leverage problem. They're trying to significantly deleverage. Just for the record, I have an underperform rating and a $3 price target on the stock, in case you're wondering about my position on that. But to be clear, they have certain assets that they can sell and perhaps use for strategic leverage. And one of the smarter things they did was take their home health agency across their hospitals and sell 80% of it to one of the home health care companies, Almost Family. And they'll retain a 20% interest and presumably create networks. And LifePoint did much of the same thing. So they did it with LHC Group. So you are certainly seeing that. You're seeing HealthSouth owns Encompass, which is a very fine home health agency company, and they have said that they've been very successful in negotiating sort of one-on-one partnerships as being a part of a post-acute network for acute care. So you are beginning to see these kinds of virtual alignments. But at the end of the day, it's going to matter. The STAR scores are going to matter. The quality is going to matter, and the readmission rates are really what going to dictate this.
Is there sufficient expertise in the post-acute sector to really do this transformation?
I think there are some really interesting things being done in post-acute from a. There are a couple of private companies that are doing some interesting things with sort of whole patient care, looking at the total episode of care and intervening at the front end so that you save money at the back end. Are they really post-acute? I don't know. I call them a disruptor because they're disrupting behavior. But within the post-acute network or the post-acute companies, I think there are some business leaders get the joke. I mean, they know where this is going. They understand that you need to be able to have a much more holistic view of the patient across an entire episode of care, and that they have to, if they're going to play a role, they have to make sure that whatever status the patient comes in at, they at least get no worse. They do get better, and the bleeding in terms of the cost of their care stops for that condition. So there are some who are willing to enter into some innovative kinds of arrangements, but I don't see much in terms of what those innovative arrangements are yet. It's still very early.
I guess it would just add to that. I think what we're still experimenting with, and probably will continue to for quite a while, is what is the best model? What are the best models? If you look at a market like Southern California, a lot of this is driven by primary care physician groups,
Who are generally at risk. Yeah.
They're yes, absolutely at risk, and generally they are the integrators of care. But outside of markets where that's evolved over a long period of time, it tends to be more companies and facilities that have emerged to fill the gap, as they are the only ones with the organizational scale and risk tolerance to pursue these types of arrangements.
And that's a great observation, because you see someone like Northwell Health that's pursued an awful lot of these kinds of innovations, who was at the front of the curve on BPCI. Sort of the interesting factoid there is that when they had two of their hospitals were in BPCI, they're the old North Shore LIJ, and so they've now become Northwell Health with aspirations from Massachusetts to Pennsylvania to DC, so they're coming. And what they found was that the cost savings to the system of avoiding a nursing home stay after joint replacement was so significant, with actual improvement in quality in their model, not just neutral but improvement, that they just sacrificed their own bottom line by changing their practice protocols, and unless there's extraordinary circumstances, none of their joint patients will end up in subacute.
Yes, it sounds like some of the early efforts, particularly under bundled payment, to integrate post-acute care has been not dependent on the capacity of post-acute care, because the patients just aren't going in to the facilities.
Yeah, they're emptying out pretty quickly.
Yeah. Good. One question about delivery systems that are either developing their own limited network insurance products, either or in partnership with an insurer, for the Medicare Advantage market or for the ACA marketplaces. What's your sense of whether we're going to see a lot of success in that area, or is it really going to be quite marginal?
My view would be marginal. I think that tends to be the experience that we've seen for the few systems that tried to do that hasn't been resoundingly positive. They haven't been walking away from it like they have from exchanges, but it's a little experiment without much success. If you talk to Kaiser, and then they are integrated payer providers, so it's a more balanced perspective, I'd say, of all. If the president of health plans there thinks that the health systems grossly underestimate the challenges that the plan side of it have to undergo to gain membership. It's the distribution advantage and all of those things that they don't have any capabilities around, population health management, building out the networks with primary care docs that are successful, all of that, which I think a lot goes into this that is not, I think, appreciated as easily by the health systems when they walk into this.
So our former colleague Carl McDonald, whom we all remember, I'm sure fondly, used to say, the managed care companies have been managing this risk for, 30 years now? And from time to time, even they spectacularly don't get it right. You can't expect hospitals to be able to manage this risk at all. That's not what they do.
Yeah, I think a consultant once told me a very concrete reason why joint ventures with insurers work better, because the insurers can get a low-price network to supplement the delivery systems network. So, but I guess it's so I want to shift to the private health plan perspectives on ACOs, bundle payments. How eager are the plans to pursue these types of reforms?
I think they're excited about the risk-sharing arrangements. They've been looking for this for a long time. They talked about it for years before they had got some cover, if you will, from DC. And now the train's left the station. Every day I look, Aetna or Cigna or one of them is talking about the next ACO arrangement that they're building out from a private plan perspective. And whatever I've heard so far on the bundling side as well, it sounds like they're very much chomping at the bit to move in that direction as well, and just piggyback off of all of the reform that CMS has already pushed forward.
Anna, I would mostly agree with you, but I think that the jury's still out on how supportive the managed care companies are really and truly being for these types of arrangements. I mean, they are entering into them. There's no question some of them they're aggressively pushing forward. But there's always going to be a tension when, it comes down to the question of delegation and giving up roles and responsibilities. Because if you look at, a delegated model like what prevails in the Southern California market, that isn't necessarily where the payers ideally want to get to if they think it through, and they may end up there. But that's a tough transition, because you talk about in a market like that, in a model like that, delegating and in a sense, offloading a lot of functions that you've been doing successfully internally for a long time.
I think Optum is doing some interesting things with Optum Insight. They talk about it as strategic relationships that they're building. They look at the readiness to take on risk quotient, if you will, among health systems, and then make a strategic choice around where they may partner with this health system on Optum Insights, which is their health IT platform. They may actually donate, some capital as well, and then build that strategic relationship. I believe right now with North Shore, LIJ, and then they have a Dignity, but they haven't been picking. They've been very selective, but it's a broad arrangement in how they're doing it. I kind of agree with Matt. I wonder about Aetna and Cigna, and if this is just all PR, or is there any substance behind it? And maybe it comes more to, not that the plans don't want it, but the incentive alignment is quite minimal with hospitals that want to fill beds. So unless you can find an equation where the contract is the win-win, it's challenging to do that. On the other hand, a primary care medical home type model that Medicare Advantage has is just an obvious win-win on both sides with the primary care doc.
We are definitely seeing, I am definitely seeing a lot more innovation on the Medicare Advantage side with respect to these sorts of arrangements, or at risk, or changes in behavior, all of the things we've just been talking about, because the nature of that market, first of all, there's plenty of opportunity to extract cost savings at a constant level of outcome, but also because the structure of how they're paid rewards them for improving patient experience, improving patient outcome, improving patient care, whereas in the private sector, depending on the contract you have with the employer, it may not actually reward you for that. So there's a very clear, as you go around and you talk to some of the primary care groups with Optum Care, who are sort of leading in this patient-centered home kind of arrangement, or any of these changes in practice patterns. I'm not even going to say it's changes in behavior. It's just changes in practice patterns. So instead of putting an end-of-life patient in the hospital, you encourage them to accept hospice. Save a lot of money, okay? But whatever it is, you're definitely seeing that more in the Medicare Advantage side, just because the savings are there and the quality metrics will reflect the fact that you get better satisfaction and outcome, which gets you better reimbursement, and so there's a financial incentive for both parties.
Agreed.
Yeah. What about, some areas, there's a very dominant private insurance plan. It's usually a Blue Cross Blue Shield plan, which is going to has an advantage in commercial rates over the other competitors. And are these people dragging their feet, or are they actually, ironically, probably in the best position to pursue this if they want to?
What's Blue Cross Blue Shield of Alabama doing?
I don't know, but I mean,
Right?
this would be.
I mean, that'd be the
Right.
question, because they're pretty dominant.
This would be a classic example of where I suspect, there's a lot of, there's a lot of internal angst at these plans about, how much of what, they've done for the last 20 years are they really, willing to give up? And, in many cases, they may have good reason to be reticent to give up those functions, because they're not necessarily things that are going to be done well when they delegate them down to the provider level. I think that in more cases than not, there's a real reluctance, and so the question of how long it's going to take and what changes in competitive patterns are maybe going to force that.
Yeah, the Blues, I think, to your question, I think they have the advantage of actually moving such partnerships forward, perhaps a competitive advantage in that regard. However, they are resting on their laurels to some degree, because they just enjoy straight discounts that are carrying them through better than the others. Also, to Cheryl's point, I think the savings are largely in Medicare, and those are much more immediate, and Blues tend to be more commercially driven, and so that reduces the incentive for them to see to see an improvement. I'm hopeful that Anthem will do more of what I've seen a little bit of. They've had a ton of leadership transition in the last 1 year and been completely distracted with all their issues with the individual market and all that. But they have started up some interesting things as far as provider partnerships on the oncology side with their physician networks to manage treatment paradigms. They've have this partnership called Vivity in Southern California with multiple providers. So very innovative things where, because of their scale, their desire to move out of being just purely local Blues and deal, just working with their discounts and mix shifting into Medicare, and they have Medicaid, that they'll do more here.
Yeah. What about the fact that half of, say, commercially insured people are in self-insured plans? And to what extent has been, working with the employer to get their buy-in to this been something that has really been a restraint on private insurers in pursuing this?
Yeah, I think it's a real factor. You can't move faster than the market or your customer is willing to move. And, some of these things that, the health plans, it's hard to get your first large-scale customer to bite on some of these more innovative ideas, or I will say even disruptive ideas, because you really are going to make some parts of the continuum here uncomfortable, and you'll have some complaints. But generally speaking, there are some employers out there. You might think about perhaps CalPERS, it used to be GE. Some of them have always been very innovative and very forward-thinking and willing to take that step of being the first to leap into a new benefit structure or a patient management paradigm. But I think that's absolutely correct. You're definitely limited by the willingness of your customer to be innovative. I think that as we get into and by the way, I think your point on cyclicality is absolutely correct. We cannot forget that this is a cyclical business, and I don't forget it. I just think that the level of the cycle may be affected by the decisions we make to use or not use healthcare at a time, but that's okay. So it's, do you start here or do you start from there? In any event, one of the things that I think we do need to take into account here is just how much these employers are screaming in pain from the cost of their health insurance bill. And the more that they find themselves unable to pull on the same levers that they did before, the more willing they are to find new levers to pull.
I mean, there are, the trend amongst employers is still towards more self-insuring. You see that happening in the middle market and even in the small group market in response to the community risk pooling rules. But at the same time, there are some signs that some of the large employers are maybe pushing a little bit in the other direction, starting to do some of what we would have called slice contracting back in the 90s. And, so that could perhaps start to enable some of the integration of providers.
When I asked the question about self-insured employers, I wasn't concerned so much about the really big ones, because those are the people that have the staffs, have the benefits consultants, who can perceive the potential. But I was thinking more about just the process of going from one 500-person employer to another one. People who don't really have sophisticated benefit staffs, that what it takes to convince them to go along. And I do know that when the Blue Cross Blue Shield of Massachusetts, went forward with their alternative quality contracts, one of the reasons they did it only for their HMO enrollees was just because of the enormity of the task, particularly in the Blue Cross Blue Shield world, of getting the self-insured employers in, because they're talking about, employers all over the country who might have employees in Massachusetts. What's your sense about which approaches to alternative payment are the private payers see as their biggest areas of opportunity? In a sense, are they focusing on the population-based or on the episodes or on the primary care
I think
approaches?
there's a recognition from lessons learned from the late 90s, when there was a lot of premature global capitation happening in markets with provider organizations that were ill-suited to take on that risk. And so I think payers are being pretty smart with it by and large, and they're approaching they're approaching the task in a very stepwise and graduated fashion. So more emphasis on episodes and a slow approach to moving towards real population-based reimbursement, and only doing that with organizations that have really proven that they're willing to or that they're able to take on that responsibility.
I think it's more primary care at this point in time. I think they're cautiously optimistic about the other alternative payment models, but there is a big focus from OptumCare to do that. Humana, I think, has pulled back a bit from buying practices, but they continue to focus with Medicare Advantage on the primary care model. And so any of these changes around macro or all of the other things proposed by CMS have an impact, possibly even to the positive for someone like OptumCare. If physicians feel that they are just so overwhelmed with the complexity, instead of selling themselves to hospitals, then there may be more opportunity to go to a plan.
The one thing that I would just say that some of the smarter health plans have learned is they try to transform a model or intervene in a way the markets are structured, is that there is no such thing as one size fits all in healthcare, that all healthcare, like all politics, is local. And so what will work in Southern California and Las Vegas and maybe a couple of other sort of risk-capable provider markets will never work in New York, where you have very strongly independent practitioners and a lot of regulation around the behavior of for-profit entities and others. So that there is a real difference, not to mention difference in population densities, and sometimes urban healthcare can be as challenging as rural healthcare can be, in the sense of, you got smaller sized markets, but you have same sort of population demographics. So there's an awful lot going on that, we have to be careful not to generalize too much. I think, as usual, where you see the real leadership of these alternative payment models are in not just Medicare Advantage, but in the Western states predominantly. Also, you've got some in Texas, because some of the development of Texas, the Medicare and Medicaid markets in Texas actually, fostered this under Pacificare. But there is a very healthy respect among all of the providers as well, who are trying to look at taking risk, for as well as the health plans, for the nature of their local market and the task ahead of changing that behavior from a fee-for-service to a risk-based model. And there will be, they're all trying to avoid the blow-ups of the past, where, the provider groups failed and Pacificare had to pay claims twice. So there's a real live example and real live incentive here to be very focused on how fast your local market really can change, and whether the population demographics are such that, including the growth rates, are such that it can support the investment that you're going to need to make in order to get these changes.
Good. One last question about narrow network plans. We've seen them being extremely important in the marketplaces. I presume that they're significant in private exchanges, but what's your sense about, thinking of the totality of private health insurance? Do you expect narrow networks, or just more limited networks than we have today, to become very important in the future?
Well, it makes sense that you're seeing it in the individual market, and you see it to a certain extent at Medicare Advantage. I mean, as maybe is pretty clear, that when you have an individual buying or selecting a health plan, it's much easier for an individual to say, well, I can choose from amongst 20 narrow network plans and pick the one that is going to work for 99% of my possible care needs, as opposed to an employer who's contracting on behalf of a geographic and otherwise diverse workforce, and is going to really only look at the capability of contracting, therefore, with a limited number of plans that have pretty broad networks. The problem here, though, is when you think about, okay, the idea behind private exchanges is breaking that open and taking the employer lives and enabling those lives to more readily select narrow network integrated plans. You've got a little bit of a chicken and an egg, or maybe a big chicken and an egg dilemma here, where the formation of lower cost narrow network integrated plans or integrated provider organizations is dependent on the critical mass of lives in things like private exchanges, selecting and buying those types of products. The flip side of it is that you're not going to get to the critical mass of those lives in private exchange-like vehicles until you already have the lower price narrow network plan options available. I mean, that's a dilemma that might seem unsolvable, but you get there bit by bit over time. But I think that's a little bit of why we're where we are now, and partly why the private exchange adoption has stalled to the degree that it has, at least relative to where expectations were at their hypiest maybe 3 years ago.
Yeah, actually, this is a good topic to get into if any of the others or Matt have more to say about private exchanges. I was going to ask you about whether they've stalled, and I guess they have, and you think that's the key reason?
I mean, I think when you look at the rationale to move to private exchanges, there are a few different reasons given. I've gone to one of them, which is not necessarily the first on the list of purchasers, Purchasers might say, well, I just want to move to defined contribution and offload this responsibility for purchasing, to the employee level and getting out of the role of being the paternalistic employer purchaser. That is clearly one of the roles, being able to, then budget that expense on some predictable basis tied to maybe some type of escalator is another rationale. And then the last one is, getting to the ability to leverage narrow network integrated plans, which I think is the most powerful of them. But all of those are really tough transitions to make, which is why I think it's been a slower process than some people had hoped a few years ago.
And the Cadillac tax is now put on the back burner until 2020, most likely gets repealed. High deductible health plans have proved to be quite effective in keeping medical cost trend down. So the need to do something as disruptive as a private exchange for a large employer, I think, and the burning platform is no longer there. So here we are with 7 million, actives. I think on the retiree side, you may continue to see more of it. And then on the small group side, I mean, there was a kind of a construct around it would help them potentially pool risk. And that might be one more impetus to build out private exchanges. I believe maybe Mercer is the one that does the more fully insured kind. Towers, I think, is more of the self-insured above 1,000 employees jumbo. But now, as we look at what might happen with the election coming back to that, with association health plans is one more option that's being tabled for small group employers to pool risk and then facilitate and ease their ability to move to self-insured and stop loss. You again might see less of an incentive to go to private exchanges.
Yeah. Is there, given the sharp movement towards higher deductibles as part of benefit buy-downs, do any employers talk about running out of room to do this? Will there come a point to say, if the deductible gets even bigger, it really, it's question, why do we get into health insurance in the first place if we're really not providing access to care? Any evidence that we might be near a point where some employers just don't see this as an option anymore?
Sheryl, I see you shaking your head.
I'm not aware of anyone who's saying that. That's what I'm saying,
Well, we're hearing a little bit of that from some of the health benefit consultants who work with middle-sized employers. We're hearing of some buy-down fatigue going on, and it's somewhat correlated perhaps with a tighter labor market.
So,
and so a little bit of backing off there. I'm not going to say that we have a characterization that that's necessarily widespread, but there's some of that going on.
So buy down fatigue as opposed to concern that the deductibles are too high.
I'm piling the two together.
Okay.
We can't go higher on the deductible's already $3,000.
Yeah,
we can't take it up to $4,000 or $5,000.
Really? You think
so? I think there's some of that going on. I'm not.
That would be good news. I haven't actually heard that, so I'm learning from you, which is great. Thank you. But I actually hadn't heard that. But I know that there's certainly beginning to be, what I have been hearing though is beginning to be from the employee side, a fair amount of pushback. Is like, whoa, wait a minute. I don't really have health insurance. I'm self-insured for the first $3,000 or $4,000 or $5,000 or $6,000 of my family's healthcare costs, and it just doesn't kick in. There's beginning to be a realization, I think, on that side. So that was why I was sort of shaking my head. I'm not hearing it from employers, but maybe just because of where I sit, I tend to get that feedback more from the consumer side.
I have heard, though, that again with the Cadillac tax, and I think I mentioned this at the beginning of this panel, that their impetus to raise the size of the deductible has now become much less. There still is headroom to penetrate high deductible health plans more within their employee base. And of course, at some point, that reaches a ceiling as well. But I've heard this from some of the third party, not the benefits consultants, but like the players like Fidelity and so on, who manage benefits in kind of an infrastructure way.
Yeah, and then as someone mentioned, we we could be moving into a tighter labor market, which is something we remember from a long time ago. And we also knew what the tight labor market did in this was the late 80s.
Late 90s.
Late 90s,
We were
that's
at a
right,
full
late 90s.
employment, internet-driven, go, gaga economy. The good old days of when we were all rock star analysts. Yay.
Speak for yourself.
Yeah, I was, actually.
So that could be another cyclical turn that could change a lot of these things. Hospital employment of physicians. How much further will this trend go?
Oh, God, I hope not much more. Hospitals are really, really not good at managing doctors. This is, we've seen this story before. It didn't end well before, and honestly, the feedback, I'll just say the observation one makes that LifePoint community both expressing some difficulty in, achieving profitability on the acquired physician practices, for different reasons, perhaps, but doctors and hospitals are fundamentally should be well suited to each other, but they're really not. So there's another issue though, and it's a financial issue. So part of the reason why the hospitals were really interested in acquiring the doctor practices was they could take them from the outpatient reimbursement schedule and make them a hospital-based unit and get immediate bump up in the reimbursement from Medicare. And again, they tried to do that also with the managed care companies to greater or lesser success depending upon the market power of the players. So if the health plan had more market power, it was a no. If the hospital was a must-have hospital in the network, it was a yes. And so, now with them basically saying, well, wait a minute, there's sort of this site-neutral thing at the outpatient rate, and that has been finalized. I think we'll see the drive for the financial arbitrage as an incentive essentially stops. And now there's got to be a real notion of integration and coordination of care and some other clinical quality reason why perhaps you should be integrated other than just the financial engineering reason. So I suspect it's going to pretty much stop because it's nothing but losses for the hospitals. The only reason why you wouldn't want to do it is you don't want to let the health plans buy them, because that's even worse.
I always thought the health plans were buying them strictly to keep them away from the hospitals.
And then make a business out of it. I mean, yeah.
Yeah.
That's creativity at its finest.
Good. If there aren't any more comments on that, we'll move on to the next topic, which is on physician consolidation. We had a conference a few weeks ago here on surprise medical billing, and one of the speakers noted how some of the hospital-based physician specialties, such as emergency physicians, have become highly consolidated into a small number of national firms. And I've seen Matt's coverage of some of them. Perhaps the others of you cover them too. And just want to comment, how extensive has consolidation become in this area, and what's been happening?
So the chief financial officer of LifePoint left his job to go be the CEO of Team Health, and 3 weeks later got acquired. I hope he got a lot of stock, and I hope he vests. It's covered for us by Ann Hines. It's pretty significant, and I'm not sure if it says that the economics of that business are beginning to come pressured. So again, you need to build scale, and you need to be able to offer benefits to these employed physicians that a bigger company can perhaps do. There probably are some arguments around that, and national contracting again may, especially if you're dealing with consolidating chains on both sides, both managed care, bilateral consolidation above and below you, managed care and other providers around you. But yeah, we've certainly have seen that, and it's it remains to be seen how successful that will be.
Excuse me, sorry.
Yeah, go ahead.
I was just going to say, one of the interesting experiments, which hasn't worked out all that well thus far, but certainly a company to watch, is DaVita and DaVita Medical Group. It's been it's not been a good acquisition for them heretofore, but I think this is a company that was looking at the eventual, if not near-term stagnation of the dialysis business and saying, what is going to be a growth engine of the future? And so they acquired Healthcare Partners, and Healthcare Partners was and is a now renamed DaVita Medical Group, an organization of primary care-led physician groups in Southern California and a handful of other markets, operating under a very advanced delegated integrated care model. And they were looking for a partner or an acquirer that was A, not a payer, B, not a hospital company, C, was large and well capitalized, and D, a healthcare company. So their list got very small, and the marriage with DaVita ended up making a lot of sense. But it's been a really tough road for them to take that model and advance it into new markets. And frequently where DaVita Medical Group has been looking at acquisitions, they find themselves outbid by the local hospital or by the payer or by both. And meanwhile, the results that they've had for their own operations have been mixed. But that's going to be an interesting story to watch.
The other example of the consolidation in this ED space, well, ED and anesthesia is pretty fragmented, and you're seeing a lot of roll-up. The two players are Team, as Sheryl mentioned, and Envision, and so you're seeing roll-up within each of those as far as staffing of hospital physicians, and for all the reasons Sheryl mentioned. There's another company, AmSurg, which is the ambulatory surgery player that bought an anesthesia company called Sheridan. And they've recently made a deal now to merge with Envision, who is the ED consolidator, if you will. And the CEO there has a vision of this conglomerate that will offer one-stop shopping across all hospital physician staffing services, ED, anesthesia, radiology, neonatal, and with their ambulatory surgery capability all rolled in. So I think, that's ways for them to try to create value by offering better rates and one-stop shopping, physician training and recruitment under a corporate umbrella. Team had enormous issues, though, when they went out of their ED and anesthesia mode into buying a company called IPC, which is a hospitalist company, and have overpaid for it, have seen tremendous physician attrition in the hospitalist piece of that acquisition. And that combined with the fact that they rejected a bid from AmSurg at 50% higher stock price not that long ago, then drove them into the arms of Blackstone, which is a private equity company, and they're hoping to turn all this around and bring stability to the hospitalist organization. Hopefully, I think they're hopeful that the bundling story with CJR and all that will also play out favorably for Team, but in a private setting, so that all of us analysts and investors aren't breathing down their neck. I think the CEO, as Sheryl pointed out, was very strongly incented to sell, and his employment contract, it was pretty obvious he was going to sell very quickly.
Both of you have mentioned various what I call efficiency things, value propositions. But what about the potential for just pure leverage? That consolidating nationally the ED docs is going to give them great leverage, negotiating contracts with hospitals. Is this something that policymakers should be concerned about?
It's still very fragmented. I think if you look at the numbers, they're not easy numbers to come by, but I think you find that I don't think we're close to there yet. Clearly, at a certain point, the answer to that is going to be a yes, but that's, from the numbers I've seen, would seem to be still quite a few years away and a lot of consolidation away.
And ED is seeing so much, so many secular pressures, I think, with the Affordable Care Act tapering off, if not even, being unraveled. Medicaid expansion lives, you may see more of a steerage from Medicaid plans away from the ED to primary care. Now that might be kind of a golden scenario, but that's a headwind as well in ED. And then the freestanding ED story, though, that one it's hard to really, sort of say whether that is bad. But all of them, in the third quarter, you saw HCA talking about freestanding ED pressures, and then Team Health missed yet again, and so the stocks had really tanked for a while on all these worries.
Good, thanks. I'm going to be moving to questions from the audience soon, but before I do that, I want to give each of the analysts an opportunity to either answer some question that I didn't get to that they really had something to say on, or just give other thoughts of reflecting on the discussion so far as to what the audience should take away.
I think talking about the small group market, we talked a ton about the individual market, but the small group market has been facing enormous headwinds. Not to say it was ever completely functional, and you had all these employers who were slowly dropping their offer rates and all of that. But I think we're now to the point where the under 50 market, you have this ACA compliant market where the companies are losing a lot of money, and there's this kind of keep what you have ACA non-compliant market, which is expected to be phased out by the end of next year. But the worry that Aetna and Anthem have, and they're probably the most exposed here, is that as these two risk pools are merged between the ACA compliant and non-compliant books of business, that the currently non-compliant small groups who are possibly healthier and more likely healthier will not be able to withstand that risk pooling. And so you have each of them now talking about how they're going. Anthem is openly, I think, pretty much saying in their earnings call that they will compromise on margin to try to retain those groups. But there's an enormous worry about what that pool risk looks like. And Aetna talking about, sort of obliquely that they would be willing to lose membership to try to recover their small group margin, because their efforts to keep margins intact this year did not play out very well for Aetna, and I think it was one of the two drivers that led to them not beating numbers that, as I think they had expected and perhaps analysts had expected at the early part of this year. The other being the individual market, which turned worse than they had hoped.
Matt or Sheryl?
Go ahead, Matt.
No, I don't have one.
You don't have one? No. Okay. So first thing, yesterday when I was meeting with some of my hospital companies, they asked me to sort of sit up here among all of my managed care friendly colleagues to sort of defend the hospital sector. It's a little hard to do that right now because I'll start by saying what I said before. We honestly do not know, let me remind you, we do not know what is going to happen. So all of the things that we've been saying here are predicated either on the continuation of the markets as we know them today or some vision of what could happen in the future. But, we come here and we're hoping through your questions to learn a little bit, or at least I am, to understand and get better insight into what is likely to happen. Because there are a couple of things the market does not tolerate well, as I mentioned. One of them is uncertainty. And the other is negative surprise being uncertainty. And we are, they are the same thing. And we are in a position now of perhaps, we're on a great precipice of great change, so that perhaps Congress can lead us in a direction where we fix the things that are wrong with the ACA, because there are many, and preserve what is good. But, from where I sit, I think it's a very risky bet. So a couple of thoughts. First of all, a very simple strategy with respect to hospitals. If reform was good for hospitals and reform is going away even before the election, it's still going away. So therefore, a lack of reform is bad for hospitals. The hospitals that I think will ultimately succeed in all of this are the ones that will be able to consolidate, and I don't mean by acquire. I mean by rationalizing the capacity that they have, because no matter what's going to happen with the ACA, you're either going to have no pay patients coming back, or you're going to have activist managed care companies who are working to manage their margin at the expense of the hospitals. One of those two things, I think, is likely to happen irrespective of the politics, because it's the economic equation at work. And if that happens, then we're going to see exits of hospitals from the marketplace. So just that's the concern, that right care, right time, right place. that the economic incentives and the technology and the innovations in care management, the quality metrics, the readmission policy, all of these things are training primary care and other physicians to keep their patients out of the hospital as long as they can. And the ones who will survive are the ones who have to survive, not the ones who want to survive. So we could be on the precipice of very, very great change, and that might not all be bad, but very great change for the hospital sector in particular. For the post-acute sector, I think I was here last year sounding the warning bell, and I hate to be Cassandra in this, and I hate to be the one always being the voice of doom here, but maybe it's genetic, and maybe it's just the 29 years in the business of just seeing things, that we said, you know, bundling is going to be very dangerous for these post-acute settings, and in fact, it's even more dangerous than we thought, even before it fully kicks in the sense that the skilled nursing facilities that were getting paid several $100s per day are now no longer seeing those heads in the beds. Doesn't matter how low cost you are if the patient doesn't show up. And now when you contemplate what might happen with Medicaid block grants and what might happen with Medicaid funding overall, long-term care facilities where your mom and dads are maybe one day, or when I might be one day, if I'm nice to my kids, it'll be a good one. They may be in very dire straits, but watch the hospitals, watch the ER admissions, watch for signs of the real changes that we could possibly see on that score. And then finally, the best thing that I think could happen out of this whole policy mess that we've gotten ourselves into, not to mention the whole electoral mess, would be for a very rapid conclusion to the uncertainty, but also for the folks to just look at the ACA with more objective eyes, to understand that it is not wholly bad and it is far from wholly good, but that if we focus on some of these innovations in payment for value, we could actually address what the ACA perhaps should have addressed all the way along, which was getting rid of the barriers for actually providing the right care at the right time, in the right place for the right reason at the right cost, which is where the healthcare system, I think, needs to go. So I'm encouraged from that perspective that perhaps the Republican leadership can get us in that direction now that they're talking about preserving at least some of the ACA, only because that's this part of the ACA that I think that actually has the opportunity to get us to a long-term better healthcare system.
Thank you. I've got time for a couple of questions. Yes, Sean.
Hi, Sean Bishop with the Commonwealth Fund. I was wondering if any of you have been looking at United Health Group's paper that they are talking to folks about. It's sort of their vision of all the things that they like, that they would like to see happen. One of the things that's in that paper is their sort of commitment to having what they're calling, I guess, entitled subsidized health insurance for the uninsured. And what they are looking for, now maybe this paper was written before the election, so maybe it's potentially moot, but we met with them after the election, so they're still talking about it, but that they want to build on the Medicaid program as a way to ensure, the uninsured. They don't think the exchanges function in their current form. I was wondering if you could comment on that vision.
Oh, I'll give it a crack.
Go ahead, Sheryl.
Okay. So first of all, how much simpler would it be? Okay, you're uninsured, you're low income, forget the mechanisms and the structures of the subsidies, put everybody in a Medicaid expansion plan. Ideally, that was part of what was supposed to happen when all 50 states were supposed to participate, but from their perspective, from a social perspective, the mechanism of doing that, you don't have to build a whole new exchange mechanism. It would have been much simpler, okay? So as one Democratic staffer once said at a conference I attended, if this was really a government takeover of healthcare, if this was really single payer, it would have been so much easier. As of January 1st, 2014, you will all be covered by Medicaid. Done, finished. And by the way, your taxes go up. That would have been very simple. But don't forget, this is a for-profit company with a very significant portion of its business coming from Medicaid managed care. So when you do block grants or when you do an expansion of Medicaid, the Medicaid managed care companies benefit. So should they be talking their own book? As if I were a shareholder, you betcha I would want them to do that. Doesn't mean it's wrong, but just remember they will benefit from this. And I do think it would be much simpler to administer.
Okay. One more question?
I think there's one here.
There's one there. Oh, Paul, yes.
Hi, Paul Hughes, Cromwell Altarum Institute. Despite the fact that we've heard for months how terrible our economy is, in a few months it'll be the third longest economic expansion in U.S. history. And when it ends, that will give all of these players opportunities to make changes that they can't make when things are going well. What kind of changes do you see happening when we get to the next recession?
Well, one thing to watch for, just if we go back to that cyclical model that we were talking about, is that historically anyway, trend has usually spiked or peaked into a recession. And, that combined with the pressure on the bottom line is what then has tipped the scales for employer purchasers to take action in terms of healthcare cost containment, or at least to step on the accelerator where maybe they weren't before. I guess it's a little hard to envision, what is the next step in healthcare cost containment when that becomes more urgent. More shifting into high deductible plans, narrow networks, but narrow networks aren't going to work unless you have employees have a broad choice of plans to pick the one that's appropriate for them and their family. So I think, it's probably going to be something around the evolution of private exchanges that is what you would see occur when we get the next, urgency call around healthcare cost containment brought on by a recession.
I think the one thing that you omitted there is thinning of the benefit. Okay, it's not just the copay and deductible, it's what's being covered. And if you get rid of the metals, as, think about, do we get rid of the metals plans as are they providing a floor for the benefits in some way, shape, or form? If you're an employer and you're looking at the metals, do you have to do better than that? Or can you do just that? Or can you do less than that? But you could also see the thinning of the benefits.
Okay, well, this is a good time to, we need to close the meeting because we're approaching noon. This room has to turn over quickly for another meeting, so it asks you to do two things. If you have cups, please take them out with you, and if you want to continue discussions with other people, please do it outside the door. I want to thank the analysts for a really terrific job.